And so it gives me great pleasure to introduce our next speaker, Professor Rebecca McKetin. Rebecca leads a program of stimulant use epidemiology and interventions at the National Drug and Alcohol Research Centre. She is the Coordinating Principal Investigator on the TINA trial, which is a phase 3 randomised double-blind placebo-controlled trial of mirtazapine. So we're very lucky to get Rebecca to speak on that for us.
Thank you, Brendan. How do I start it? Oh, there we go. Excellent. So as Brendan said, I'll be talking very briefly and very quickly today because I think we're running behind time about the TINA trial, which is a RCT, double-blind, placebo-controlled RCT phase 3 trial of mirtazapine, 30 milligrams a day. I have to apologise, we are not quite ready to present the results. We're hoping to get them out in the next month or so, but in the meantime, what I'm going to do is just tell you a little bit about the trial. I think one of the things that we found interesting about the trial, which is the population that we captured, and hopefully that will help inform other people doing clinical trial work about how to facilitate recruitment. So very quickly, by way of background, 2 phase 2 trials done in the US with samples of 60 and 120 respectively found signals showing that mirtazapine could help people reduce their methamphetamine use. They found a reduction. It was fairly modest, so it suggests to reduce frequency of use as opposed to looking at abstinence or anything like that. But both of those studies were conducted in very narrow populations of men and transgender women who had sex with men, so high-risk populations, and also in very controlled environments, being phase 2 trials where people got lots of other help. And so our question was, well, if we were to put this into clinical practice in Australia, would we see this same benefit? And that's what's called a phase 3 trial. We got funding, thankfully, from the MRFF, which was fairly generous and enabled us to do a really good, solid study. And we were targeting 340 people who had methamphetamine use disorder, so stepping it up in terms of the volume of people coming into this trial. So our intervention was 30 milligrams of mirtazapine. That's what was used in the 2 US studies. There's no other rationale for it, really. It's a standard dose that's used for depression as well. And we looked at 12 weeks. The benefits in the US studies were seen at 12 weeks. And if you've ever conducted trials with people who use methamphetamine, you'll find that the attrition increases dramatically after that time. So we felt like there would be diminishing returns. So we stopped at 12 weeks. We did follow people up after that, but we didn't do any medication after that. I think one of the important things about mirtazapine and the other medication trials that I've been involved with is that you can deliver the medication as a take-home medication, and that's really critical. It makes it much easier to implement. So, and it's just my perspective and the type of research I do. That's what I like doing. You can see here, in order to do that, we monitor adherence, and you can see the little bottles there that show people if they've taken the medication in the hope that they won't take it more than once a day, so it reduces risk of overdose. That also gives us data that we can use as an objective measure of adherence. Our trial's a little different than some of the other trials that you might be familiar with. Trials where people normally come to the hospital and they get their medication, they go home again. I've adapted methods that I'd used in longitudinal epidemiological studies, and rather than waiting for people to come to us, we have a model where we go to them. And this is an example of one of our sites. We had 6 sites around Australia, and this is the team in Perth, Michael Christmas, who's a doctor there who provides a medical support, who some of you will know. But also we employ through UNSW a research officer. And in this case, we've got Lily Palmer, who's there full-time. She works in the service, and it's her job to concierge people through the service, through the trial. It takes the burden off the people in the service from running the actual trial, and she does all of the clinical trial assessments. Importantly, in doing that, we can bypass a lot of the strictures of the area health service. We can pay people, which is very helpful, and improves retention. We can also do field interviews. So we do get the person in to see the doctor at the start of the trial, but thereafter, we can actually go and meet them somewhere that's convenient for them, less threatening for them, and safe for them. So that has enabled us to get really good follow-up in this trial. But also it's enabled us to reach out beyond the services. So rather than waiting for people to front up at Next Step in Perth for treatment or what other drug service we were using, we actually went onto Facebook and did a really aggressive social marketing campaign. And we also put up flyers and stickers and brochures through NSPs. And you can see here an example of that. And if people were interested, they could go to our website and there's an online register. They can express interest, and our research officers, who are trained, very empathic, very approachable people, will call them back or get in touch with them by text or email, whatever they want, and tell them a bit about the study and see if they're interested. So doing this, what we were able to do is recruit quite a lot of people through Facebook. And we did use a little bit of other Insta and TikTok, but being an old person myself, I think I got a bit stuck on Facebook. But we'll work on that next time. We also were still recruiting a lot through NSPs and word of mouth, which are our more conventional methods of recruitment. So who did we get? I think it's important. We got a lot more inquiries than the number of people we actually screened. But we screened 1,200 people, so it shows you how many people are out there interested in these studies. And quite often we couldn't get back in touch with people, so we lost a lot at that point. But we were able to randomise 344 in the 2 years that were open for recruitment, which is pretty good going for a clinical trial of this nature. And we were also using those field methods, got good follow-up. I did mention the medication adherence there was 62%, and I'll come back to that at the end of the study and why I'm mentioning and explain why I'm mentioning that. So our criteria was having a moderate to severe methamphetamine use disorder. And the people we got in were using daily or almost daily, so the median was 24 out of the past 28 days of use, so heavy methamphetamine use. But what started to become apparent is that we were getting a lot of people who smoke methamphetamine, whereas quite often in services you get more people who inject. And we're getting more employed people, so we're kind of capturing a broader sample. And importantly, about half of them had never been to treatment for methamphetamine use before. This didn't overly surprise me, but it really struck with it was surprising to the clinicians on the study. They're like, we don't see these people in our service, they've not been here before. What's going on here? So out of interest we've looked at that a bit further to understand who these new people are. And I've just done a quick analysis for you. And I'm scared to press the thing in case yeah, that's good. We've looked at people who hadn't been to treatment for methamphetamine use before and compared them to people who had. So the right column is people who've never been to treatment before. A little bit older, again, that's, I think, an artefact of Facebook advertising. But here, this is interesting. So this is where we're getting that broader, more employed group of people. And also, they're living in private accommodation. Fewer of them have been to prison before. And they're not getting other help much either. So these are people who have not really had help for their methamphetamine use before, and they're more likely to be employed, and less likely to have prison history and living in private homes. So not showing those classic signs of social disadvantage that we see in the people who are going to treatment. What I found particularly interesting is when we looked at their methamphetamine use, they've been using for longer, or about the same amount of time really, maybe slightly longer, and that's probably an age thing because they're a bit older. Less likely to inject, more smokers. That doesn't surprise me because there's no NSP equivalent for smokers, so less likely to be engaged with services or know about them. They're using actually a little bit more in terms of days of use. So the use is, it's similar, but they're not light users. They're still up there on the scale in terms of their use. Better mental health. So less depression. Insomnia is not really that different. And here we've got less anxiety. HIV risk is also a bit less, which is probably because they're more likely to smoke. Quality of life, marginally better. So what we're seeing is a group who they're still using as much methamphetamine, if not slightly more. So it's not that they're not using as much, but they've got slightly better health. And that explains perhaps why they're less likely to go to treatment or why they're less likely to have come into contact with services. Just comparing their recruitment avenues, you can see here people with no treatment history in green compared to people with a treatment history. They're more likely to come through Facebook, so our social media, internet advertising. Not really, they're still coming through our conventional routes like NSPs and word of mouth, but this is where we're really accessing more of them, and you can see the same on the other internet. So it's the internet that's capturing these people more often. Practice implications. I think I was asked to include a slide on this, so I hope this is appropriate. But thinking about this, from my take home is there's an unmet need out there for methamphetamine pharmacotherapies, people who are interested in that might not have otherwise gone to treatment. And it struck me that a lot of these people were genuinely unaware that treatment existed or that there were treatment options available. They were very not well informed about what was out there. And to capture this population, we needed to broaden our recruitment avenues for treatment. I think particularly the internet has a lot to offer in accessing these people. And a lot of our treatments aren't necessarily accessible for people who are employed, partly because of the stigma and the risks, but also just the hours of service. And the role of contingency management. So, I mean, we pay people to come to our assessments. That's a form of incentivisation, very basic form of contingency management. But I think in our trial, one of the things that we did consider doing when we put in the grant was implementing a form of contingency management, a very simple form of incentivising people to take the medication, because adherence is a problem. It's hard to get people to take the medication regularly enough to get a signal. And I thought a lot about this, and I had a real problem with the possibility that we might be paying people to take a medication that hadn't been shown to be effective and might have unknown risks for their health. I think particularly if people were experiencing adverse reactions, the common ones for mirtazapine are drowsiness and weight gain, so not too big, but also the risk of suicidality or unstable mental health, that they might continue to take it when in fact they should stop taking it. And I think the final clincher was, well, if you pay people to get better adherence scores on the medication bottles and you're going to pay them, they'll just take the lid off and they won't necessarily take the medication. So we took a decision not to do that. In closing, I'd like to thank the very big investigator team behind this trial, and most of all the TINA trial research team who did all the interviews, incredibly hardworking, amazing people who gave us those great follow-up rates. Thank you.